So we talk about oxygenation. We can assess oxygenation with mucous membrane colors. Again, cyanosis is not the end all that they need oxygen. It is kind of end stage, they need oxygen. We can utilize our pulse ox. I don't rely on my pulse ox too much to tell me things. We can certainly do arterial blood gases if we need to. We may not see cyanosis in patients that are shocky because they're going to be pale. Same thing with anemia. Or patients with a SpO2 greater than 80%. It's never, again, acceptable to utilize gum color as a sole indication for oxygen status. So again, we want to, if they look like they need oxygen, I'm probably going to give them oxygen until the doctor is able to assess them more and we can figure out what's going on with them. So oxygenation, again, is the amount of oxygen the animal can supply to its vital organs. So there's something called the oxyhemoglobin dissociation curve, and what it is it tells us our how much oxygen is available in the blood as compared to what's bound to the hemoglobin in the blood. And one of the really important things when we start talking about pulse ox that we really want to pay attention to is our pulse ox isn't measuring oxygenation, it's measuring saturation of our hemoglobin. So what that means is if there's a lot of different things that can affect if we're able to get oxygen to our vital organs. So we'll talk about affinity in 1 second, but also it's important to know that hemoglobin can also bind things like carbon monoxide. It can bind cyanide. It can bind, it can turn into methemoglobin. So those things are going to read out 100% SpO2 because your hemoglobin's bound. It just isn't bound necessarily with oxygen. And methemoglobin is oxidized hemoglobin. So you guys in Australia have, like we have in California, where we have these massive wildfires, right? Like Los Angeles just burned really bad this year. But the last decade or so, we had some pretty massive wildfires, and you guys get them too every now and again. So you might have patients come through the door that are coming in for fire-related injuries. And one of those fire-related injuries we'll see is carbon monoxide toxicity on those guys, right? Because they're breathing in carbon monoxide from the fires. Those guys are going to pulse ox at 100%, even though they are severely hypoxic, right? Because carbon monoxide is going to kick off our oxygen off our hemoglobin. So that's one of the reasons that we want to be kind of cautious about utilizing our pulse oximetry, again, via our end all. So this oxyhemoglobin dissociation curve, we have what's called, so first it shows that it's not a straight relationship between the saturation, which is on the left here, and then our PaO2, which is the oxygen that's available in the arterial blood. And then you also have something called shifting. So you can have something called left shifting, which is caused by things like acidosis, hypocapnia, and then something called 2,3-DPG, and then hypothermia. So when we have left shifting, that means that the hemoglobin is going to have more affinity for the oxygen molecules are there, which means it might be saturated, but it's not going to let go of that oxygen and hand it off to the tissues that need it. So when we start talking about these things, these guys are often hypocapnic because they're having difficulty ventilating, and they're also hypothermic because they are having difficulty letting go. They're not perfusing their tissues, and they're alkalotic a lot of times because they're breathing off a lot of that carbon dioxide. So those guys are going to have higher affinity. So even if they are pulse oxing at 100%, they may not be releasing that oxygen to their tissues. So their tissues may still be hypoxic.